Okay, good morning, everybody. I wanted to echo everything that Ty just said. A huge thank you to all the perfusionists and healthcare workers out there for doing such an amazing job during this time of crisis. And a very special thank you to all of our loyal custodial community. We really appreciate you. We hope to see everybody here in person next year at this same time. So be safe and take care of your families. And so with that, I'd like to start by introducing my talk today. I'm going to be talking about myocardial protection and post-bypass recovery. We're going to talk about essential pharmaceuticals, custodial HTK and how it works. Take a look at the delivery protocol and the effects of hemodilution associated with bypass, and then look at post-bypass EMUF. So Essential Pharmaceuticals, who are we? We have the exclusive distribution rights of custodial HTK in the US. We've been serving the transplant community as well as the cardiac community since 2006 here in the United States. So custodial cardioplegia, let's start out there. This was developed by Dr. Brett Schneider and Professor Preuss. This was developed in Germany in the early 70s, so this is not new technology, but it is tried and true. When you look at a bag of custodial HTK, I like to break the components down into the top four as the arresting components and the bottom four as the protecting components of the solution. And you'll notice that these are in millimoles, and so that if you dissect the millimoles in half, roughly you're looking at about 7 milliequivalents of potassium in the solution. So very little potassium concentration, negligible calcium, and low potassium. And then the other components, the histidine, tryptophan, and ketoglutarate.
Bill.
Sorry. Yes, sir. You're not seeing.
No, we're not seeing your slide presentation
or
sorry. Your PowerPoint.
Let me get back here. It says share screen. I apologize, guys. Are you seeing this?
Not yet, Bill. Here we go.
Okay. Sorry about that.
Now we're seeing your holder. Now.
Gotcha. Okay.
You're online.
Gotcha. Sorry about that, folks. I am the guinea pig for this whole process, and so here we are. So taking a look at the components again, really quick there. The components, as noted, the top four are the arresting components, and the bottom four are the protecting components. I'm going to breeze through that now. It's an intracellular solution, as you're all very well aware. The low sodium, the low calcium. It reduces the action potential. So reducing that sodium and calcium level, you cannot generate enough positive ions to create that action potential. So therefore, the heart stays akinetic for as long as the solution is within the myocardium. So then we get on to the protecting aspect of the components of custodial HTK. And we first look at histidine. And histidine, in my opinion, is the secret sauce to why this is such an effective myocardial preservation solution. Histidine is an alpha amino acid. It does a great job of protecting inflamed tissues by scavenging oxygen reactive species, and inhibits cytokines and growth factors that are involved in tissue damage. But what it does a really nice job of, if you could appreciate this graph here, is you've got the pH here and the ischemia of the myocardia down here on this axis. And the top line is the custodial HTK, and the bottom line is your standard 4:1 St. Thomas blood cardioplegia. And at 0 of the myocardial ischemia, we start out at 7.4. We're all pretty much the same. But as soon as you start getting out to 30 minutes, at custodial, still almost no change in the pH. But when you get down to the St. Thomas, and you're just below 7 pH, so that's typically when you'd want to go ahead and redose actually your blood cardioplasia at that maximum 30-minute mark. But taking it all the way out here to the 2-hour mark, which we kind of recommend a second dose for Custodiol, you're still just under a pH of 7.0. So the heart is protected because of the buffering capacity of the histidine. And if you could appreciate, there was 198 millimoles of histidine. Our blood, which also helps buffer, has 2 millimoles of histidine, so quite a difference there. So then you get to the T of the HTK, tryptophan, and that's just a membrane stabilizer, an anchoring protein, and that facilitates the transition of the sodium and calcium ions in and out of the cell for very quick action. So when you take the clamp off, the Custodiol again is still in the microvasculature, and it'll help transport that sodium back in. And you typically see a quicker normal sinus rhythm than you're used to seeing with typical blood cardioplasia. And then the ketoglutarate, obviously it's the energy source. It's there for the post-ischemic phase, just like giving a hot shot. So that's why it's often unnecessary to give a hot shot, because you already have the advantages of having the ketoglutarate in the microvasculature already for when you take the clamp off. And then mannitol. I know I went over it quickly, but we have a pretty high dose of mannitol in Custodiol. And as purported in Cardiopulmonary Bypass, the third edition, its greatest effect is at the beginning of an ischemic insult. So what a better time to have a high dose of mannitol in your myocardial protection solution than at the very beginning, because we're creating ischemic insult when we put that cross clamp on. And it's also another oxygen-free radical. So we have that same scenario of protecting the heart over and over. And it also has some renal protective qualities as well whenever it's reinduced systemically back into the system. So let's jump into how we deliver it. And this picture is just your basic coil and bucket, and a system that a lot of us are familiar with and have used in the past. And I put that there because that's all you would typically need to deliver Custodiol HTK. And I'd like to mention that it's unnecessary to adjust what kind of equipment that you use. So you could use your standard 4:1 ratio. You could use your Quest system. It's adaptable to whatever you're using. So there's never any kind of capital cost associated with using Custodiol for your clinical cases. So going over the protocol, it must be stored refrigerated. So has to be kept cold. And then, like I said, any kind of standard cardioplegia ratio set can be used. And we deliver Custodiol at 3 to 4 degrees Celsius, like most cardioplegias. And we give that at 20 millimeters per kilogram at a maximum of 2 liters for the initial dose. And this is for adults, obviously. And then subsequent doses are delivered at the same temperature for half of the loading dose. Initially, Custodiol, we deliver it at 125 millimeters of mercury until we get an electrical arrest. And then we'll typically back that off to an infusion rate of about 80 millimeters of mercury for 5 or 6 minutes. And of note here, it's more important that the rate and time are correct as opposed to the total volume. So we're not just shooting for 2 liters even. We're real concerned with the rate and time. And then common sense, make sure that the heart's not distended so that you get really nice even distribution of the Custodiol throughout the myocardium. And then, like I said earlier, recommend between 90 and 20 minutes, a subsequent dose might be necessary. So, you get to the 2-hour mark and decide where you're at in the procedure, and if you need to give another dose. And if you do have to redose, if you've got quite a bit of work left to do and you redose, you are resetting the clock back to another 2 hours. So unless you're in a really, really difficult case, it's unlikely that you'd ever give more than 2 doses of Custodiol for an entire procedure. And then continuous hemoconcentration, Z-buffing, is probably necessary if you don't vent it, but we recommend venting whenever possible through the right atrium. So some of the benefits: low viscosity for improved flow rates throughout the microvasculature. It allows for rapid cooling of the myocardium. Reduced potassium levels allows for quick release without any harmful effects, especially to the kidneys. There's no kidney load of that high potassium. It's got superior buffering when compared to blood. We went over that. And there's one recognized protocol. So you should expect to see the same results every time because you're doing it exactly the same way every time. It's not varied for procedure or surgeon. And then there's no additives necessary. So no compounding whatsoever. So if you get an emergency, you pull it from the refrigerator, hang it, and go. And then retrograde's often unnecessary because it protects the right heart so well. Some of the challenges: hemodilution is obviously a challenge. This is a 100% crystalloid cardioplegia solution. So we recommend, like I said earlier, scavenging whenever possible. And then hyponatremia. So you will see low sodiums if you do not scavenge. And you could treat that or not treat it. It will resolve naturally without any intervention. So it's not harmful to treat it or to not treat it. So I want to change gears and look at that challenge of hemodilution for the rest of the talk. So hemodilution, we're giving 100% cardioplegia, so it sounds like it should be, hemodilution should be an issue. But when you look at this paper that Stammers and his team put out, looking at all the different protection strategies, it really doesn't seem to matter what the hematocrits are, how much blood products are used. Typically, if you look at the hematocrit, the custodial group is actually slightly higher, not statistically significant, but slightly higher. And I think that's because we use ultrafiltration to optimize every patient. So we're not selectively deciding which patient we should optimize their hematocrit. But does that mean we're done with it? I should stop right there. No, there's still a lot of work left to be done. And this paper proves that point. The group out of this cardiovascular anesthesiology clinical practice improvement group, they note here that over the last decade, with all the strides we made in blood conservation, that our high-risk patients are still, 50% of them are still getting blood products. So there's still a lot of work left to be done here. And some of the recommendations that they gave for perfusion in particular were minimizing bypass circuits. I think we're all doing that. Wrapping in some form, and that is often very much utilized. But this last one, modified ultrafiltration, I think this is where we could dig in a little deeper here because it's not as widely used for the adult population. And when they did a retrospective study of 573 patients, they did note that these patients did have reduced inflammatory mediators and had lower transfusion requirements as compared to the non-modified ultrafiltration group. And this study put out by Zakar and his team in the thoracic surgery annual show the exact same thing with adult cardiac modified ultrafiltration, showing a decrease in inflammatory mediators as well as reducing blood product and transfusions, and showing some improvement in cardiac output index and systemic vascular resistance. So there is proof that this does work out there, but again, I don't often see it in everyday practices. And then this, our folks here at perfusion.com, thank you very much for keeping us informed. This was just put out by Anesthesia. And at this critical time during this pandemic, now more than ever, that we should use some common sense principles to blood management and do what we can to reduce the risk of transfusions, because we really don't know if this virus is transmitted through potential donors. So we should be doing all we can. So what can we do? Well, I think EMUF is kind of some low-hanging fruit. I think this is an opportunity for us to explore this a little bit more and do some more prospective studies to to help prove that this could be a source of reducing blood product usage in our patient population. What is EMUF? Well, it's basically extracorporeal modified ultrafiltration. Sometimes it's known as offline MUF, and it's been around for a very long time, and most of us have seen it occasionally or have tried, single pass modified ultrafiltration and giving whole blood back. But this is the process of multi-pass ultrafiltration of your cardiopulmonary bypass circuit. And there's what the circuit looks like. But why should we EMUF? Well, it improves the post-bypass hematocrit, and that's pretty obvious. And it also improves hemostasis. We're saving the patient's viable platelets. We're preserving their clotting factors. And end of the day, it is the patient's own whole blood. So we're giving back exactly what was in the patient prior to separating from cardiopulmonary bypass. So Hemobag is a way that you could do that EMUF, and it's been around. It's been around for quite some time, but I think it's a good time to reintroduce it back into the picture and taking a look at the circuit. It's a very simple circuit. Here it is. It's a separate system that you put into your existing cardiopulmonary circuit. It's one sterile circuit and allows you to do a controlled multi-pass hemofiltration of your circuit and give back a high quality product. And so I think it's one of the solutions that we should start investigating using. And here's some of the clinical data that was put out by Ross's team out there in Salem, Oregon, and showing increased hematocrits. You can see that up 8 points, improving the platelet counts, and improving fibrinogen, and lowering the PTT and INR. So they showed that they gave this high quality product back to the patient. And then the group from Pittsburgh also demonstrating preserving all these clotting factors that are so important at a time when the patient needs it most, when we're off bypass and giving protamine and trying to produce hemostasis. So I think this is a great system. And I think here's some of the reasons I feel we should consider Hemobag for the EMUF process. It just standardizes the whole process. We've all been there. If we tried to do some type of EMUF, we've cut and spliced our circuit and tried to make a circuit multi-pass, but it becomes very arduous and confusing, and this standardizes it. So it reduces the operator error, and you get reproducible results. So you're going to see the same results every time when you use the exact same circuit. It reduces the risk of infection. You've got one sterile kit. You just insert the kit and start processing. And I've seen this in action. It enhances the team approach to blood conservation because you've got the surgeons and anesthesia all actively engaged in providing the patient with whole blood post cardiopulmonary bypass. So with that, I want to thank everybody. If you have any clinical questions whatsoever, there is my email, wnicotra@essentialpharma.com. And with that, I want to introduce Dr. Gneiden and Kevin McCusker. They've been conducting research for over 25 years together, and today they're going to be showing some of their latest findings.
Opportunity for us all to get together and share with us a week, a couple of days of science and perfusion. So we're looking forward to that. And I'd also like to thank the perfusion.com team for all the effort they've put into making this happen. Having been involved in the prep work up to this point, it's really shocking to see how much work their whole team, Brian and his team at perfusion.com, puts into this. So it really is extraordinary. So we do have a lot of information here to get across this morning. We will be tight for time. So as my Monsignor says at Mass on Sundays, let us begin. So we want to continue the research that we've talked about in several of the other Sanibel meetings. And our title for today is going to be Myocardial Preservation by Single Shot Cardioplegic Techniques. So we've been at this game I personally, in the field for 32 years, we've done a lot of research in looking at glucofiltration, biocompatible coatings, circuit modifications, so much so developing a circuit for under 800 mLs, where we've titled everything condensed circuitry, never mentioning in any of our publications about mini bypass because we haven't miniaturized anything. We've condensed the circuitry to go ahead and use those products that are offered by our manufacturers, but altered the pathways and how we go ahead and we utilize them. The other part of the stuff, the IP that we've patented, is also in microplegia. So when the single dose quadriplegic solutions came in and were being offered in our armamentarium, we felt obliged to go ahead and open up laboratories and gather some clinical data as well, and go ahead and start publishing about this. So our topic today is going to be myocardial preservation by single-shot quadriplegic technique. We have no conflicts of interest. All studies here that we are going to mention are our own work, and we are performed in an independent setting. We do want to highlight that my research partner, Professor Canadian, is now the chair at Ankara City Hospital campus, quite proudly. And it's a new facility. And yes, those numbers underneath are actually correct. There are 3,804 hospital beds. There are 675 ICUs and 128 ORs. It's one of the largest medical centers in the world. It's about the size of several shopping malls in this country. So quite large. So our outline here is concept of myocardial protection, single dose solutions, recent research we want to cover that we've gone over, our projects, experimental, clinical, and we'll finish with some nuclear imaging work that we've done for studies looking at these hearts that have received these types of solutions 30 days out. So when we start with any point of research, we go ahead and look at the amount of literature that's out there for us to go ahead and work our way through. So within cardiac surgery to date, there's over 400,000 publications, close to 21,000 on the pediatric and myocardial protection is about 13,000. Myocardial preservation, about 5,000 under that topic, and about 16,000 publications in cardioplegia. Fewer in cold, warm, crystalloid myocardial techniques, publications in retrograde and antegrade techniques, but very little data is out there about these single dose solutions. So start to talk about that. So the single dose solution that we're all most familiar with, which is presented and talked about quite a bit, is Dr. Pedro Del Nido's solution. Dr. Del Nido is a pediatric heart surgeon at a Boston Children's Hospital. He had a patented solution that is now available to everyone. That patent has run out. And it was developed for his pediatric patients. So within that cocktail, we take a 1 liter bag of plasmolide A, that's their base solution, and they're going to go ahead and add the following. So it's 16.3 mLs of Mannitol, 20%, 50% magnesium sulfate, 4 mLs. So about 4 milligrams. Sodium bicarbonate, 8.4%, 13 mLs. 13 mLs of potassium chloride. So that equals about 26 MEQs in that cocktail, and 13 mLs of lidocaine 1%. The delivery is the mix is 4-to-1 crystalloid with blood. Multiple centers do give 8-to-1 or further out on that. And the calculation is to give about 20 mLs per kilo at 8 to 12 degrees, but no more than 1 liter. And, they do say repeat only if the cross-clamp time is greater than 3 hours or electrical activity at the surgeon discretion. Well, bulk of centers where we are involved and we use it, they pretty much go about 1 hour out before redosing. Some centers we can talk about go 90 minutes. And I would like to hear from other centers that go further out and would love to go ahead and analyze what's happening there. So the idea behind this is the that it will reduce the energy consumption for the heart. It blocks calcium flux into the cells. It will go ahead and, as far as hydrogen ions, it's scavenger. It preserves high energy phosphates, promotes anaerobic glycolysis during myocardial rest. And I put in bold here, it does not keep the heart cold. I was just recently in a large medical center. We were sharing our data with that at Grand Rounds, had the opportunity to go into their ORs, 4 separate ORs, and they were using Del Nido, and went into 4. There was not a heart based upon, we could quickly look at the TEE because they were not using myocardial temperature probes, but based upon the TEE temps, there wasn't a heart that was colder than 32 degrees. So that is a concern. So Dr. Del Nido does not suggest that any of this be involved for the adult population. Remember, he's operating strictly on pediatrics at Boston Children's. He cools all his patients to 22 degrees. And to date, in our publications, we've written that there's greater than 200 different modifications of this, but we're probably getting data back where we're almost up to 300 different modifications of Del Nido. So everybody has their own formula for this. It's a breakdown. A lot of people taking away the plasma, 1 liter bag of plasmolite A, and mixing it either in with the Quest system or in a syringe system, and using an algorithm to go ahead and give that directly into the heart. But the lidocaine dose is a very important part of this. So the other single dose solution is HTK, the histidine, ketoglutarate, and the tryptophan. The histidine is designed for that acidosis anaerobic long ischemic time. The ketoglutarate is there in the solution for the ATP production during the reperfusion. And the tryptophan stabilizes the cell membrane. So the HTK, it's a sodium depletion of the extracellular spaces, and that causes a hypopolarization of the monocyte plasma membrane, inducing a cardiac arrest in diastole. Coronary distribution through retrograde hemodilution transfusion is a concern, but it's not a concern if you can modify it. Lidocaine dosing dilemma, data on limited population and limited clinical parameters, which are studied. No data on long-term outcome other than what we have published. And the cost, it's very inexpensive to do now. These are things that we readily can pull from a Pyxis and mix. But HTK, the histidine, tryptophan, and ketoglutarate formula, pediatric, used for both pediatric and adults, single formula, has satisfactory evidence in the adult valve and many types of surgery. And coronary distribution for retrograde hemodilution transfusion. There is talked about a sodium dilemma, but through hemoconcentration, this is quite something that can be corrected quite easily. And there's data on a limited population, limited clinical parameters are studied, and there's no data on long-term outcomes other than what we have published for 30 days. And at this particular point, there is a cost associated with that. So questions we break down through these single dose solutions. Which patients do we choose? Pediatric adults, which types of surgery, pediatric adult valve, adult CABG, outcome of the myocardial protection, early postoperative war. So we'll then now start to look into where our research states. So the current literature, always equivalent and or better early outcome than conventional techniques in pediatric populations, what it's stating. Mostly equivalent and or early outcome than conventional techniques in adult valve surgery. Conflicting data on a limited amount of adult CABG population, and there's very limited parameter studies through troponin levels, temperature, etc., and no data on long-term outcomes. So Specialty Care had recently published a paper, which we thought was interesting. The fact that when they've looked at for CABG, AVR, MVR, in the CABG AVR form, it appears that a greater percentage that the teams would reach than for the HTK solution. And another publication from that team It's also showing when we talk about transfusion or hemodilution effects is that there is slightly more in the del nido as opposed to the HTK, but relatively close. So our projects, which are experiments, and we've published, so we have, as we spoke before, we have several laboratories where we can go ahead and do this, and we have large clinical sites where we can gather a lot of patients in a short period of time. So, we focused on a direct cellular effect of different cardioplegic solutions, and we've documented them long term, and that we believe are most underestimated facts about cardioplegic topics in the literature. So we presented this in 2018 at the Heart Valve Society, and we went ahead and looked at long-term protective effects of single multi-dose cardioplegic solutions in cell culture model. So we went ahead and we gathered 3 types of cells. We pulled from neonatal cells. Those are the H9C2 cells. We pulled myofibroblasts, which are L929 cells, and the adult cells are the UVEC cells, the human umbilical vein endothelium cells. And what we did is we did cell viability with MTT proliferation assay. And that takes time to do the MTT proliferation assay. We did that until 48 hours, and we did membrane integrity studying through the LDH studies, and we continued those for 24 hours. And people said, well, it would have probably your research would have gone a lot quicker if you used the MTS proliferation assay as opposed to MTT. But with MTS, there's probably a little bit more colorimetric interference that goes there. So we wanted to get true good imaging, good sampling, so we stuck for the long-term MTT. That study, our aim was to test single-dose cardioplegic solutions compared to conventional, based on cell viability, cell integrity versus time. Let's go ahead, and we wanted to demonstrate long-term myocardial protection. So cell viability, MTT analysis with respect to time until 48 hours, cell membrane integrity, functional evaluation with the LDH test until 24 hours. Also, we needed to underline the answers to the questions. Is it acting better on pediatric adult or the myocardial itself? So we went ahead and we took 96 wells, right? So we looked at the L29s, which were the myofibroblasts, the human umbilical vein.
Believe we've lost audio.
Yep.
Vein endothelial cells and the primary neonatal cardiomyocytes. And we used del nido. We put them in, like I said, 96 wells of del nido, HDK, blood, and St. Thomas. We had a baseline temp of 34 degrees for 2 hours of 32, 6 hours of 36, 24, 36, and 48 hours, 36. So what were findings in those cell cultures? So when we look at the data that we retrieved from the L929 cell culture and the fibromyoblast, and looking at the viability studies, you can see 2 hours, 6 hours, things start to change early on in the 6 hours. And 24, we start to see the HTK climb, and really in the 48 hour, the HTK solution outperforms the del nido, pledgisol, blood and pledgisol in the control. And we go ahead and we look at the HUVEC, the human vein endothelial cells culture. And these are adult endothelial cells. 2 6 hours, relatively close. Start to see the change again in the viability studies in the HTK solution, and the longer we go out to the 48-hour point, really start to see a difference there. But here, like we figured what we would find, in the primary neonatal cardiocytes. Those are the H9C2 cell cultures. And in these viability studies, the 2 hours, 6 hours, 24 HTK and del nido relatively same, and then long-term in the 48 hours, it goes out where the del nido, the viability, outperforms the HTK. So when we look at the percent for cellular disintegration, we want to do the LDH cytotoxicity test. So in this cell membrane integrity, it's a functional evaluation. So here, all relatively close, start to see changes. This is in the L929. In the H9C2, we start to see less cellular disintegration with the HTK as opposed to the del nido, also in the UVEC and the L929. So other studies that we did, then we go ahead and we put things under the electron microscope, and we'll do a fluorescent microscopy imaging. And we'll use ecridine orange and propydium iodine staining to get these colors that we're going to show you here. And when you go ahead and look through these slides, the red-orange colors are non-viable cells, and the green fluorescents are those viable cells. So you see what our control is. Plegisol does not perform well in these studies, blood and plegisol, but you can see the HTK is a very vibrant fluorescent. There are many viable cells there, as is the del nido, but HTK performs there. So when we do the microscopy imaging for the H9C2 and those primary neonatal cardiomyocytes, and we did this imaging at 24 hours, you can go ahead and you can see how vibrant it is in the HTK and the del nido. So the other thing we want to talk about now is you'll start to see more in the literature, and we've started to analyze this in our laboratories, is microvascular integrity, glycocalyx. So what is glycocalyx? Glycocalyx is it's a pericellular matrix. It's a glycolipid. It's a glycoprotein. It's within all human beings. It's in all animals, fish. Hopefully we've all caught fish in our lifetimes. And when you hold the fish and you start to rub your hands across it, you can feel that slime that's there. Well, that's the glycocalyx. We're doing multiple studies on this, but this is a study, some of that research, and we presented it about last year at the Academy meeting. So we titled this Safety Dilemma of Long-Term Protection of Del Nido, HTK Cardioplegia, and Minimally Invasive Valve Surgery, Clinical Impact on Microvascular Integrity, confirmed by the our cell culture data. And what were the results there? Well, the results, there wasn't a significant difference among the groups with respect to demographic data, BMI, and change in the troponin 1 levels at T1 or T2. But there was early perioperative data, which we demonstrated all three types of the cardioplegic techniques provided effective clinical outcome with similar effects on blood biochemical parameters. So the cross-clamp time in that group 1 was 72 minutes, group 2, 69, and 60, a lot less shedding of the endothelial glycocalyx. So we want to show you those imaging of what that means and put them under the electron microscope and you get the imaging. So you can start to see the shedding more here, the breakdown of tissue in that endothelial tissue, HTK and del nido. And here, these are the microscopies. So thing you want to look at is the more brilliant color of the red is more shedding that's occurring. So here, the upper portion here would be the HTK. The mid-level is the del nido, and the St. Thomas at the bottom. So less shedding in the HTK, very similar, if a little bit more in the del nido, and far more in that St. Thomas solution. So our projects, some clinical data that we want to talk about. I think I'm going to run out of time, so I'm going to turn it over now to Professor Ganeda. Thank you.
Thank you very much. So Can you hear me? I'm going to continue. And so I'm going to talk about the clinical outcomes of our studies when we compare different single-shot cardioplegic techniques. So we started with the long-term effects of cardioplegic techniques in the early studies, and we compared about 100 patients from each group, like St. Thomas as control, blood cardioplegia 4:1, then Nido and HTK. So we evaluated the patients in the ICU until they are discharged, and after discharge, we follow up the patients up to 1 month and 3 months. So in the early postoperative period, there was not any significant difference with respect to any clinical parameters, even in those 100 patients in each group. So with respect to the enzyme levels or length of ICU stay or inotropic support or whatever. So after the operation, we just fixed some kind of inappropriate signs, let's say, to follow up in the early postoperative period that shows us a good idea about the myocardial preservation. So we fixed that if the patient has a kind of tachycardia over 100 beats per minute, or bradycardia or arrhythmia, or some kind of problems, symptoms like shortness of breath or edema or some signs of heart failure, this will show us the inappropriate, or let's say not sufficient kind of myocardial preservation. So we use a LifeWatch mobile system. It's a telemetry system. It's a very small machine, like an iPhone. You connect it to the patient like this, and then this monitors all the parameters of the patients for 24/7. And we just demonstrated all those data in a live fashion. So if anything, any problem occurs, then we receive an SMS message, and then we can interfere with the treatment of the patients at the same time. So we have the data like this, data sheets, like measuring every time the blood pressure, arrhythmia, or any kind of parameters in the early postoperative period. So when we check this data, we can follow up only 78% of the patients we've done, like as you remember, 100 patients in each group. So in the 30-day follow-up, the HTK group was very much satisfactory, and especially less incidence of tachycardia or bradycardia, and some less incidence of diagnostic symptoms. So at the 3rd month follow-up, we could only follow up half of the patients. And when we checked of that, the incidence of tachycardia and bradycardia, the diagnostic symptoms were significantly more in the Dalnido group. So this was the initial study to show us the long-term follow-up of the patients receiving different types of cardioplegia. Another research topic was to test those signal dose techniques in minimally invasive surgery. As you know, they are becoming more and more popular in the minimally invasive surgery area. So we compared again those 4 solutions. Again, in the early perioperative period, we didn't demonstrate any significant difference with respect to any clinical parameters like this, like cross-clamp, ventricular fibrillation rate, length of ICU stay or inotropic support, etc. But again, in the 30-day follow-up, again, we have arrhythmia problem in the Dalnido group, especially in the long term. And then we just continued to do research on these single dose techniques. And one other concern was the hemodilution. So we compared the hemodilution effect of those groups with respect to control groups. And the primary endpoint was to understand the perioperative transfusion of allogeneic red blood cells, or secondary endpoint was the hematocrit change. So in those types of groups, when we use single dose cardioplegic techniques in our clinical practice, we always use ultrafiltration at the end of the operation. So the volume, so these are all very long-lasting operations with a cross-clamp time of about one and a half hour or something like that, 90 minutes or more. So when you deliver St. Thomas every 20 minutes, then it becomes, again, the same volume that you give in the single dose technique. So there is not any significant volume difference with respect to different cardioplegic techniques in that group. And as I told you, we always perform ultrafiltration with those single dose techniques. And at the end of the operations, in the clinical period, in the early clinical period, there is not any significant difference with respect to hemodilution if you perform ultrafiltration with the single dose techniques. And this is the follow-up of the patients from the baseline up to discharge. So I believe if we use proper techniques to follow up those single dose techniques, there is no problem of hemodilution. So we also use some imaging techniques. So there is very important radiopharmaceutical. It's called iodine-123 MIBG. This shows us the innervation capacity of the heart. It's a technique that we always use to follow up transplant patients. But in this study, we just follow up these single dose cardioplegic techniques in the long term to understand if there is a kind of innervation perfusion defect. Because if there is an innervation perfusion mismatch, that means arrhythmia in the early postoperative period. So at the first two lines, you see the MIBG level and thallium level. One shows the perfusion, the other shows the innervation. So the figure ups is the Dalnido and down is the HTK. So as soon as we just follow up those patients for 50 patients in each group, we demonstrated perfusion innervation mismatch, which may cause very serious arrhythmic problems in the postoperative period. And also, as my colleague told before, we just focused on endothelial glycocalyx and aquaporin levels. So aquaporins are new biomarkers that shows us the handling capacity of a cell to deal with the water content or volume content. So when a cell confronts with a high volume overload, it then produces aquaporin molecules to handle this. It's over the capacity, then the cell cannot produce aquaporins, and the cell failure and cell destruction occurs. So we compared, again, 3 different groups at that time, single dose techniques, course versus control, St. Thomas. And we also created another group that we include the repeated dose of cardioplegic techniques, because this becomes another problem. For example, in our clinical practice, when we use HTK, we can go up to 2 hours. But when I use Dalnido, I always want to give a redose after 1 hour. So we also try to understand the impact of this additional dose, because they are additional volumes. And at the end of this, again, we have the same format to do ultrafiltration at the end of every operation. But this is a very important clinical outcome, because for the first time, we can see some kind of differences in the early postoperative period. So when you give a repeated dose of the cardioplegic techniques, you have more problem. So you have more blood transfusion as expected, and you have a worse cerebral desaturation as expected, and you may have more low cardiac output. And also, we just check for the aquaporin content, and in the Dalnido group, in the repeated subgroup, so handling with this volume overload was not satisfactory and significantly worse with respect to other control groups. And this is the microscopic image that we take from the right atrium biopsies. So the upper level, and you can see the edema in the cell on the right-hand side, right up, and comparatively a better one in the right lower pictures. So as the conclusion of this last study, we say, okay, myocardial preservation is a very important issue, but it's not the problem that we operate the patient. We keep them like 5 days to 7 days in the hospital, and we discharge them, and the problem is over. Because we don't know anything in the long term what happens to those patients, and there are still many concerns and many questions about the redosing and the additional volume overload and how those cells are dealing with this hemodilution. So, and it's an ongoing topic, and we're going on our clinical research. This because myocardial preservation is still a concept without clear and specific clinical science, and every unit is having their own protocol, own formulas. So it's a really very interesting area for debate. So thank you very much, and we are ready to receive the questions. Thank you.